Now, there are two phases of ventilation. Ventilation consists of inspiration and expiration. Both depend on changes in thoracic volume that alter intrapulmonary pressure. Gas always flows from higher pressure systems to a lower pressure system until equilibrium is restored. This principle applies regardless of whether breathing is quiet, forced, spontaneous, or mechanically assisted. Inspiration is active. It's an active process that requires muscle contraction. The diaphragm is the primary muscle of inspiration. When it contracts, it flattens and moves down or inferiorly, increasing vertical thoracic diameter. External intercostal muscles elevate the rib cage, increasing both anterior, posterior, and lateral diameters. Together, these actions expand thoracic volume and initiate airflow into the lungs. As thoracic volume increases, the lungs are stretched outward because they are mechanically coupled to the chest wall by pleura. Remember that structure we talked about before. Intrapulmonary pressure then drops by approximately 1 millimeter of mercury below the atmospheric pressure, the pressure occurring outside. This is sufficient enough to generate airflow because there is a difference between the two. At the same time, intrapleural pressure becomes more negative, reinforcing further lung expansion. These pressure changes are small in magnitude, but physiologically powerful. During quiet resting inspiration, the diaphragm is doing most of the work. This is an energy efficient design. The diaphragm is fatigue resistant and well suited for continuous activity. At rest, accessory muscles are not required and breathing is largely subconscious. Now, during increased ventilatory demand, such as during exercise or respiratory distress, the external intercostal muscles are going to contribute more substantially to inspiration. By elevating the rib cage, they further increase thoracic volume. This layered recruitment of muscles allows ventilation to scale with metabolic demand. So, thinking about then forced or deep inspiration further, it recruits accessory muscles, including the scalene muscles located here in our neck, our sternocleidomastoid or SCM, our pectoralis minor, and erector spinae. These muscles further expand our thoracic cavity, generating larger pressure gradients and drawing in more air. Clinically visible use of accessory muscles can be a sign of increased work of breathing and potentially respiratory distress, and it's something we can document in a medical chart note. Quiet expiration is normally a passive process. Inspiratory muscles will relax, thoracic muscles decrease, and the elastic recoil in the lungs allow for our allow for the lungs to start to collapse naturally without force. When elastic recoil of the lungs starts to occur, this increases intrapulmonary pressure above atmospheric pressure. Therefore, air will flow out of the lungs down its pressure gradient until pressures equalize. No muscle contraction is required for expiration at rest. Forced expiration, on the other hand, is an active process. Internal intercostal muscles will depress the rib cage, while abdominal muscles will compress the abdominal contents, pushing the diaphragm up. This greatly increases intrapulmonary pressure and accelerates airflow out of the lungs. Forced expiration is essential during exercise, cough, and clearance of airway. So again, at rest, expiration depends on the elastic properties of lung tissue. If elastic recoil is lost, as seen in conditions like emphysema, this could turn expiration into an active energy consuming process, which is a major contributor to the dyspnea or shortness of breath that occurs in obstructive lung disease. Active expiration involves our abdominal muscles to contract, which decreases thoracic volume by increasing intra-abdominal pressure. This mechanism is particularly important in conditions where, with increased airway resistance, where passive recoil alone is insufficient to expel air. Our internal intercostals will pull the ribs downward and inward during forced expiration, and this action reduces thoracic diameter and contributes to rapid pressure increases within the lungs. These muscles are silent during quiet breathing, but become critical during high ventilatory demand. Now, we'll come back, I believe, and talk about this. Actually, I think we'll discuss this slide and then we'll take a pause. Many behaviors involve airflow but are not primarily used for gas exchange, such as coughing, laughing, sneezing, yawning. They all modify normal respiratory rhythm. They often involve reflex pathways inside the body, and these actions highlight the respiratory system's integration with our nervous system, neural control, as well as protective reflexes.